Welcome to Ask Dr. Mingle, the Q&A series answering your questions about quality programs and the transition to value-based care. I'm Kyle Breckel. I'm a digital marketing specialist at Mingle Health, and I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Hi, Dr. Mingle.
Good morning, Kyle, and good morning to all of you tuning in. It's great to see you again. I'm Dr. Dan Mingle, and I'm here to answer your questions to the best of my ability.
We have a great set of questions today, but before we get started, I want to remind folks that they can always send us their questions. If you have a question for Dr. Mingle, please leave it in a comment on YouTube or LinkedIn, or send it to us in an email at hello@minglehealth.com. So our first set of questions today comes from Becky, and for some context for Becky's questions, Becky represents an emergency medicine group, and she has a series of questions about MIPS Value Pathways, MVPs. Becky's first question today is, we're evaluating Qualified Clinical Data Registries versus Qualified Registries, QCDRs versus QRs. Will QCDRs continue with MVPs as well as QRs?
Great question, Becky, and timely considering that this year, 2023, is the first year that MVPs are available. My answer with one disclaimer is yes. The disclaimer is it's hazardous to make any confident predictions of future Medicare actions or policies. They do have an inclination to surprise us. But with everything I see, you can expect both qualified clinical data registries and qualified registries to continue to serve MVPs. In fact, all existing quality submission mechanisms are represented in the 12 MVPs available for 2023, the first year of MVPs. Medicare has aggressive plans to continue to build out MVP measures and groups. To me, that means they're going to have to continue to aggressively seek out and offer measure choices from all the available solutions. To remind you about MVPs, MVP users have to choose 4 of the quality measures available in their chosen MVP. MVPs average about 10 available measures, with a range each of a minimum of 7 and at most 14 measures in the MVP. MIPS CQMs that can be offered by both QCDRs and QRs are by far the most commonly available measures. They average 7 MIPS CQM measures per MVP, with at least 4 and at most 12 choices per MVP. Most qualified registries offer any of the available MIPS CQMs. QCDRs tend to be specialty specific. Medicare permits them to submit MIPS CQMs as well as their QCDR measures, and most will offer the MIPS CQM measures that are wanted and needed by the specialty they serve. The second most common mechanism is eCQMs. 2 MVPs have no eCQM choices. The average is 3 and the range is up to 8. In third place comes Medicare Part B claims. You may remember Part B claims as requiring fake CPT codes called QDC or quality data codes. These can only be used by small practices. That's those with 15 or fewer clinicians. 10 of the 12 MVPs have claims measure choices attached to them. There's an average of 2 choices per measure with a range from 0 to 6. If you're a small practice choosing claims measures, you don't have to submit a full complement of 4 measures if you submit all of the claims choices in your selected MVP. In fourth place is QCDR measures. 6 MVPs include QCDR choices. 6 have none. There's an average of 2 per MVP, and one of the MVPs has 6 QCDR measure choices. CAHPS survey is an available choice in 4 of the MVPs. Even administrative claims are represented amongst the MVP quality measure choices. Medicare calculates administrative claims measures from practice claims submitted for billing. Unlike the Part B claims measures, administrative claims don't require any unusual or fake entries in order to calculate the measures. It all comes from the existing CPT and diagnosis codes that are commonly included on a claims submission. 2 MVPs each include one administrative claims measure. So I hope this answers your question, Becky, and provides an introduction to the MVPs for our other listeners.
And that leads us into Becky's second question today, which is, I'm curious if we know performance rates of a QCDR versus a QR. We are wanting to do a cost-benefit analysis of each option.
Great question, Becky, and it's a valuable concept. You're essentially asking if I'm delivering great performance to my patients. Is QR or QCDR more likely to appropriately reflect that high performance in the submissions made on my behalf? Unfortunately, I don't know of any way to get to that comparison. Historically, in the PQRS system, that is the physician quality reporting system that preceded MIPS, if you can remember life before MIPS, Medicare did do a comparison of the mechanisms in every year's annual feedback report. However, that's old enough now. I don't know that we can rely on that, and it really looked at number of measures rather than comparative performance. So again, didn't answer the question you're asking. Now, there is some indirect data comparing eCQMs to MIPS CQMs. Nearly all eCQMs have an equivalent or near equivalent measure in the registry MIPS CQM measure set. Medicare sets annual benchmarks based on performance rates received and observed in annual submissions. Benchmarks are typically lower for eCQMs than for MIPS CQMs, meaning the performance scores are routinely lower for eCQM users than MIPS CQM users. Now, there could be a common cause. Factors that lead to the adoption and use of eCQM measures could also predict lower real performance, but I theorize that understanding the nature of documentation standards and workflow requirements, the requirements of the mechanisms to be populated, I suspect that equivalent performance is falsely downgraded by the strict measurement requirements and comparative lack of flexibility represented in eCQM systems compared to MIPS CQM systems. But there's no such comparison between QCDR and QR processes. They use the same specs, the rules grant them the same flexibility, they share benchmarks. The observable differences are in capability, flexibility, and measure choices offered by those vendors serving each of those mechanisms. QCDRs are likely to have fewer choices, less flexibility, and fewer capabilities than QRs. QCDRs generally specialize in a single specialty. They draw clients from a subset of practices and providers nationally, just those in the specialty they serve. QRs, being generalists, draw from the entire pool of practices and providers nationally. Additionally, if you are a single specialty group, a QCDR tending to be specialty specific is more likely to meet your needs than the more varied needs of multi-specialty groups. Considering the variety represented in the existing 12 MVP specification sets and extrapolating forward to an aggressive MVP development process, I expect to see all measure types represented indefinitely going forward. Particularly if yours is a multi-specialty group, you're likely to ultimately need mixed submissions drawing on multiple mechanisms. Good luck. It's going to be an exciting ride watching MVPs being implemented.
Absolutely. So Becky's third question for you today, Dr. Mingle, is it looks difficult to get each of our measures up to the full potential 10 points. What advice do you have for us to get there?
The MIPS rules are deliberately designed to make it hard. It'll be a hard task to get maximum points for all measures. You're not scored directly on performance. Each measure is assessed for its percentile rank amongst all submitters. Only the top 1% of performance rates gets a score of 10. Your practice has to be in the top 1% on each measure to get top score. To be in the top 1% of all practices nationwide will take scrupulous attention to the details of your submission. Remember, though, with grading on a scale, you will be competing with all other practices. Many others are also driven to be in the topmost percentile. We expect benchmarks to be progressively higher and harder to achieve over the years. So, what are those details to give scrupulous attention to? First, you need to systematize your great care. Make sure that invariably the care being measured is being provided. It's a team process in your practice. Second, you need precise documentation of the care in a way that the documentation is accessible to your measurement system. Third, you need to confirm that your measurement system is appropriately interpreting your documentation. Fourth, you need to regularly monitor your performance metrics. It might be weekly, it might be monthly, it might be quarterly, but you need to look at your performance metrics regularly, and you need to dig into them to understand where you can improve. In the course of regular monitoring, self-audit a sampling of each of the performance categories. Look at your not mets to make sure that accurately represents your care. Look at the performance met, make sure those are being caught, and look at the exclusions to make sure that those are all accurate. And finally, sixth, regularly identify and correct the deficits that you find. Harkening back to the prior question on comparing vendors, those that can guide you through the continuous cycle of improvement are your best choices of vendors.
Great. And that leads us into Becky's final question today. She asks, understanding the CAHPS, if our facilities do CAHPS, how am I to know if that can be a measure for a physician group on the MVPs?
Oh, great question, Becky. The CAHPS survey is an option in 4 of the MVPs available for 2023. The emergency department focused MVP is one of them. If your facility is doing CAHPS, there's still a few issues to have in mind while you're considering use of the measure for your purposes. One, the CAHPS option required for MVPs is specifically the CAHPS for MIPS clinician and group survey. Your facility may be using a different survey. For the purposes of the MVP, the applicable patient population to survey is the patients attributable to the group using the MVP. Again, you might not have that focus at the facility level survey. There's a minimum sample size that scales with group size. If you don't have the case minimum, you can't use CAHPS. Until recently, CAHPS couldn't use CAHPS unless you were a group of 25 or more providers, but now Medicare is permitting it in groups of 2 or more with a new case minimum that's at 125 patients for those smallest groups. Medicare warns that the CAHPS for MIPS clinician group survey is optimized for primary care. Make sure that you want to be assessed on the issues that are assessed by the survey. I suggest a discussion with a survey vendor serving your facility. Include the liaison person from your facility who works with the surveyed vendor. Maybe there's a simple and affordable extension on the scope of the effort that can serve your MVP needs. Thanks, Becky.
Yeah, thank you, Becky. And our final question today is, in the context of group submissions for traditional MIPS, in discussion of the APP, the APM performance pathway, and now in the discussion of MVPs, MIPS Value Pathways, a lot of our clients and friends and contacts are asking, are eCQMs the right choice for me?
Great question. We're getting it repeatedly from the public. The answer is, with careful attention to your specifics, eCQMs can be a great choice. But there's a lot to consider. First, there's measure choice. For which mechanisms are the measures you need specified? There's 47 measures specified as eCQMs. There's 172 measures specified as MIPS CQMs. And 26 of those measures are specified both ways. There's a version for each eCQM and MIPS CQMs. The APP measures, that is the 3 measures in the APP, can be done either way, as eCQMs or MIPS CQMs. MVP is all over the place. The only mechanism that offers 4 measure choices in all 12 available MVPs is MIPS CQMs. Second factor is your practice EHR status. You have to have an EHR to do eCQMs. Your EHR has to be current with certification and be certified. Does your EHR offer the measures you need? EHRs are not required to certify and offer all of the available eCQM measures. Is it affordable? I've found wide variation in EHRs. Some include eCQM service with their license or subscription fee, so there's no additional charge to submit eCQMs. For others, it's an add-on service for which they charge extra. Sometimes it seems that extra charge is priced not to sell. What is your organization EHR status? Is your organization on a single instance of the same EHR? If it is, eCQMs are more feasible. If it's not, you're going to need to normalize and aggregate the data to be able to analyze together as an eCQM. And then you're going to have a vendor run those eCQMs, because once it's outside of an EHR, it's not going to fit the eCQM measurement process that is specific to each EHR. If you need to normalize and aggregate the data from multiple EHRs in order to report eCQMs, is your reporting process from documentation to data submission entirely electronic? Is that same reporting process entirely certified? If non-electronic or uncertified in any link of the chain, it puts you at risk for invalidation of your submission. You might be able to get by year to year, but once there's an audit, they may pick up on this and may invalidate that audited years, and may even look back and invalidate past years of submissions. If your organization is on multiple EHRs or some of your practices are still on paper charts, does your central data repository include enough data to meet data completeness criteria? For 2023, you're required to report 70% of each measure's denominator, that is, having access and assessing and reporting on 70% of the denominator. In 2024, that requirement is queued to increase to 75%, and it's expected to increase in future years even further. For 2023, if more than 30% of your data is electronically inaccessible, your eCQM submission will not be valid. How about your documentation standards and compliance? To accurately assess your performance with eCQMs, it is not enough to have given the required care, it must also be documented. It is not enough to document your care, it must be documented using the required workflows and standards. Common threats to your documentation include: 1, documentation workflows that vary between clinicians. 2, documentation that is part of a narrative textual summary rather than as discrete data in a limited field or entry box. 4th, documentation that is not created from a standardized data set. And finally, documentation that draws from a variety of different standardized data sets. Final concern is the stability of your organization. If your measured entity is data compliant today, how likely is it to still be compliant tomorrow? As you add providers and practices to your organization, all of the issues we've outlined must be refreshed as you grow, to keep your quality measurement accurate and compliant. If it fits, eCQMs can be a solid and cost-effective solution for you. All of these barriers can be overcome. They can be overcome in a multiple EHR setting, and they are easier to overcome in a single EHR setting. In our experience, most of these barriers are either not applicable to MIPS CQMs, or the solution to them is faster, easier, and lower cost in MIPS CQMs than in eCQMs.
Thank you to everyone who contributed feedback for that last question. And thank you to Becky for her 4 great questions today. And of course, thank you, Dr. Mingle, for sharing your insight with us today.
Thank you, Kyle. And thank you, Becky, for all the great questions. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your experience. Ask your questions. We can be smarter together.